we'll have, inshallah, a very nice short communication with two professors of our colleagues in Abu Dhabi, United Arab Emirates, Professor Maki Fayyad and Professor Salim Awad. Salim, are you online with Maki?
Yes.
Okay.
Are you hearing us or no?
Thank you for joining us this afternoon, Salim and Maki. And inshallah, we'll enjoy your clinical cases. Please start.
I'm sharing my Mac. Are you sharing mine? You find it now ready?
You see the slides?
You see slides?
We see you.
Oh, you see the slides?
You can share your presentation.
I shared my slides. It's not shared?
Hey, Jama. Okay.
Is it there?
I see your pictures. Miss IT case UAR. Okay. Go ahead.
Salim. Okay, Salim. Go, Salim.
First, I want to thank you for inviting us to this meeting, and we really enjoyed your meeting today and previously, and I hope we'll have this mutual communication with Egypt as we have with other countries regularly every Thursday, and we'll send you and all the communication, whatever cases we see weekly, we discuss them with our colleagues in UAE and abroad. This is the public health priority in Abu Dhabi since 2003: cardiovascular, road traffic safety, tobacco control. Then comes the cancer prevention, and we are enrolled in cancer prevention for colon cancer. So we have many missed cases in the UAE. First, we thought celiac disease was non-existent or very few. And I came once to Egypt and talked about celiac disease, and at that time people were not aware much of the celiac. And I think in Egypt you have more than 1.5 million people having celiac disease. Then we have multiple autoimmune diseases, IgG4 infections with the Yersinia, which is missed by many places. And we had one professor from Scotland who said he never seen Yersinia. And I told him, maybe you don't have camels. We need to send you camels from UAE. And Yersinia can also be found in pigs. Tuberculosis is really challenging to diagnose, especially in patients with combined Crohn's disease, solitary rectal ulcers, lichen planus, herbs-induced diseases, and we have here in the nearby country, which is Yemen, they use gout, and we have at least every year patient coming with cirrhosis from the use of herbs. Lynch syndrome, hyperelastic syndrome, Dr. Maki will talk about. We are in the region in the Middle East for which familial Mediterranean fever is common, and eosinophilic esophagitis. We are seeing cases every week. Net tumor, Wegener's disease, Cowden's disease. We reported these cases in the World Gastroenterology Congress, Russell body gastritis, and achalasia. This is my case, and it is challenging. Maybe Dr. Siraj will help us in the diagnosis. This is a 62-year-old Yemeni who was using gout before, treated in Cleveland Clinic in Abu Dhabi as Parkinson's disease for 7 months with minimal improvement. He had MRI of the brain showing hyperintense focal area in bilateral frontal white matter and left subcortical parietal region, suggestive of chronic ischemic changes. He was having my diabetes and Pechi T lesion, central pons and midbrain, all goes with ischemia or Wallerian degeneration. He was seen in another hospital, a big hospital in Abu Dhabi, in New Medical Center, because of the tongue discoloration and wet mucus, and they did a biopsy which shows fungal infection. So he came to us in ACDS with dysphagia and difficulty in swallowing, and it showed meniliasis and esophagitis. This patient had long-standing of diabetes and hypertension and hypothyroidism, and a year ago he had bilateral carpal tunnel syndrome, which was operated. Dr. Siraj, in this scenario, what do you think the diagnosis will be?
You need the diagnosis from my side?
Yes.
I don't know.
Many other people don't know. Okay.
Any help from Egypt?
If we look at this tongue, we can describe it.
Yes.
But the background of the multiple pathological diseases you mentioned, it is perplexing. It is fissure tongue, irregular tongue, and there are lateral indentation, maybe from teeth.
Yes.
But there is a fissure at one of the left, could be traumatic, chronic trauma, immune
Indentation of the
deficiency.
and this tongue, this means
Yes,
Yeah,
a lot
Dr.
of things.
Siraj.
Yeah, it is not spot diagnosis, yes, Salim.
A big tongue.
It's a big tongue, and as you said, the sign of it's big, it's that there is indentation from the teeth which is pressing on this big tongue. So the diagnosis with all this scenario of having hypothyroidism and sinus lesion, and the patient coming to you for endoscopy, I would think that the patient may have amyloidosis. So what you will do? The biopsy was taken from one hospital, but they didn't stain for Congo and they missed the diagnosis. So the biopsy, when you take for suspected, you have to stain for Congo, and he had then bone pain, and he had a biopsy from the bone marrow, and it showed these aspirates of plasma cells and cytoplasmic lumbar cells, and this is a case of primary amyloidosis. It's a plasma cell dyscrasia caused by deposition of protein fragments derived from abnormal immunoglobulin light chain. The mean age is 63. The men are affected more than female. In most patients, the amyloid light chains are produced by low-level expansion of indolent B cells, clone, that arise in context of monoclonal gammopathy of undetermined significance. Next. So multiple myeloma with lumbar light chain excess, presenting as bone marrow, showing 25% of abnormal cells with translocation. This patient's systemic amyloid, because of macroglossia and carpal tunnel, a scintigram showed no evidence of systemic amyloid. Cardiac MRI was done, showed no evidence, but after 1 year of treatment, he had cardiac MRI, which showed evidence of cardiac infiltration by amyloid. Next. The diagnosis of amyloid require the identification of amyloid fibril in the tissue. On microscopy, these fibrils show pathognomonic apple green bifringence of Congo red light chain. If this patient was treated in UK, next, and he had daratumumab, bortezomib, and dexamethasone, he improved well, and he came back to Abu Dhabi with dysphagia. We went again and did endoscopy, and there is infiltration of amyloid in his esophagus. Next. We don't know what to do now because of his dysphagia. Next. And this is the biopsy from one of the lymph nodes, so showing amyloid deposits. Next. On Congo red stain. Now Maki will take over. We have a difficulty with this patient now, with the difficulty in swallowing, and he sometimes food goes to his lungs, and we are planning to do a PEG tube, or if you have any suggestion, Dr. Siraj,
Sanjitas.
send it us. We can discuss with it. Dr. Maki, please.
Thank you. I think this is interesting now. Number one, thank you, Shiraz. Thank you, Dr. Wali, Riyad Al-Wakil, and Naima Amrani for actually promoting us to the this World Gastroenterology Master of the World. Thank you very much. We are part of the group that will serve our countries. And I think me and Salim are the two rare physicians and gastroenterologists. We made all the groups in Abu Dhabi, the IBD group, the celiac group, the CRC group. And I think our objectives for that young patient, young colleagues, to describe the importance of detailed history and physical probe examination, evaluate patient morbidities, aware of the rare presentation of the common diseases, aware of the presentation of the uncommon diseases, and present missed cases from our area. Actually, during the 8 years we stayed in our center, we have seen the GIT diseases are the major cause of death and disability in the Middle East and North Africa. The patterns change, the prevalence, incidence, mortality change by country, and I think a research topic is needed for obesity, cancers, IBD, GERD, Helicobacter, celiac, genetic, and missed diseases. The future actually, there will be less infections but more IBD. There will be high living standard but more obesity epidemic and diabetes and cancers. I think the future is the research is the road to change, and it is brainstorming cases that I present for our young researchers in our area. As Salim said, we have so many missed diseases, and I think coming to the celiac disease, this affects 1% of the world population, increasing the diagnosed. Unfortunately, it's always misdiagnosed. Many phases for celiac disease really being underdiagnosed, and this is the presentations can be. The studies in UAE showed the prevalence of 2.3% of the population. That is quite high, higher than what mentioned in the world. The clinical presentation, it affects all the specialties. General physician sees it as anemia, gases, weakness, altered bowel habits. The gastroenterologist will see it as mouth ulcers, diarrhea, abdominal pain, reflux, itching. The dermatologist will see it as itching and dry skin. The endocrinologist will see a thyroid disease, hypertension, diabetes, and deficiencies. The dentist will see it as enamel changes, poor dentition, and mouth ulcers. The gynecologist will see it as infertility, disturbed menses. The hematologist will see anemia. The neurologist will see it as epilepsy, dizzy spells. The oncologist as cancers. The orthopedics as easy fractures. So it's a disease that every doctor should know. The celiac disease associated with other diseases, dermatitis herpetiformis, Down syndrome, selective IgA deficiency, type 1 diabetes, thyroid disease, liver disease, neurological disease, and infertility. Actually, the disease now, you see, I will mention this story now from our center. This lady, she is 20 years of age, Emirati. She presented to us with abdominal pain following the use of acne medication. Her past history, she was diagnosed as nephrotic syndrome at the age of 11. The father is hypothyroid. Mother has adult onset diabetes. The brother is obese with itching and abdominal pain. She was missed by many big hospitals in both UAE and the USA.
Applying.
She come to see us. The first thing we did is anti-gliadin antibody. It was very, very high, 20 times the normal. This is her biopsy by endoscopy. You see classical serration of the fold, thin and serrated folds, classical folds, and the biopsy shows subtotal villus atrophy. And this is actually the first case of nephrotic syndrome associated with the celiac disease that we published. Reviewing the world literature, you see many cases actually of nephrotic syndrome associated with this disease. Celiac disease is common, is not just European disease.
By the way, the patient proteinuria improved.
Completely normal on gluten-free diet. The atypical presentations are more typical. Highest in North Africa, by the way, Sahrawi, the highest in the world. Affect 1% of the world population, 2.3% of the Emirati. In Iraq, we have no data. Some people come with brain calcification. Some came with the dizziness. Some with vertigo.
Epilepsy.
And actually, many cases now are published, actually. We have many patients with infertility, where you have Misa and Dr. Salim. One of the ladies spent many millions for infertility and went across the whole world, came to Salim. Her son is called now Salim, yes? In our practice, we see it labeled usually as the irritable bowel syndrome. So please check every irritable bowel syndrome for celiac, finger clubbing, recurrent mouth ulcers, anemia, vitamin D deficiencies, itching, reflux symptoms, thyroid disease, infertility, elevated liver enzymes, which is transaminitis, headaches, and affect all the ages. In the past, we think it was very low in prevalence. Now it's increasing in prevalence, actually. We have seen many cases from Iraq and Syria. And I think I'll stop here for the celiac, and I'll continue to the next presentation. Coming about the colon, the asymptomatic colon cancer in the young. Our data in the UAE showed that we see cancer of the colon 12% below the age of 40. I'm sure in Egypt the same scenario. This patient, he's a 36 years male, came with no symptoms with his wife. Actually, his wife was ill with gallstones, and he read the brochure for the colon cancer. He came to a colonoscopy, and this is the colonoscopy. 1, 2, 3, 4, 5, 6, 7 polyps, and comments. And the biopsy for these polyps, one of the polyps also, and this is the polyps that is resected completely, and this is the biopsy. Intramucosal cancer, completely asymptomatic. We have seen about more than 15 early cancers during our 8 years study here. In 20 years time from now, the cancer will be the leading cause of death. So be careful in all areas. 30% of cancers are prevented by simple measures, and 75% of cancers have no family history. Our problem now here is the type 2 diabetes, obesity, and cancers. And the cancer by 240 will be the rise, tremendous rise in the cancers in the area. The global cancer rise actually in diabetic and obese. There are 12 cancers rising from thyroid to the liver, to the pancreas, to the colon, esophagus, stomach, and the breast and the cervix. So we started here screening program doing colonoscopy every 10 years at the age of 40, or fit test every 1 year, not 2 years now. We changed it now to every 1 year. And the data now, which we saw that 40% of the cases are below 50, 12% below 40. We don't want to see the cancer like this. And I think in Iraq there is the chromosomal abnormality because of the radiation. The program started here actually. In Abu Dhabi now, it's the cancer colon is the first killer cancer in Abu Dhabi. 40% below 50, 12% below 40. Screening is a must. And all the audience who are at the age of 40, please screen your colon. Our prevention program continue primary prevention, secondary prevention, primary by exercise diet, secondary by colonoscopy and fit testing. The rise is tremendous in our area, and there are some people who work in Iraq from UK develop cancer at the young age, exactly like the Iraqis. Coming now to the more other thing that we usually missed. I think there was very nice talk today about this syndrome, the ischemia of the bowel. The vascular compression syndrome in the abdomen is always missed. We have seen it actually in the arterial, venous, or visceral form. I'll present some cases. This one, the first case we saw, she's a lady, she's 42, from the UAE citizen, referring to ENT as recurrent sore throat, acidity, gases, nausea, hunger pains, felt a lump in the throat, bout of dysphagia, dizziness, and unsteadiness, with low backache, treated for antidepressants for 20 years. Bizarre symptoms, recurrent UTI, hypertension, neck pain, headache, shortness of breath. So everybody thinks when we do endoscopy, interestingly, we saw pulsation in the middle part of the esophagus. And when you compress the area by the scope, the pulse in the right hand disappears. Please remember, this is a sign of the syndrome. And this is the syndrome actually of the aberrant urinary artery. So this lady has this actually. This is the, you see the area here now almost narrowed in the middle of the esophagus, which is pulsating, and has CT scan show compression by the recurrent aberrant artery. This lady actually, she did endoscopy, this one, and then we do surgery for her, and she was actually improving after surgery. It was done in Cleveland. Now the other case actually of the supramesenteric artery syndrome, which we have now more than 20 cases in our center. This is an example of this center. One of these ladies, she's 21 years of age, from Yemen, single. Her BMI was low, 14. She has recurrent attacks of abdominal pain radiating to the shoulders, with dysphagia, especially eating rice, and with bilious vomiting. She has severe constipation, admitted in Mafraq Hospital, peg tube was inserted for nutrition, it was pulled out, and nasogenital feeding failed, and with low potassium level. She was sent to us from the insurance actually as second opinion. In the family history, there's father's goiter, mother goiter with colonic disease unspecified, 2 sisters GIT upset, and she was labeled as psychiatric illness with antidepressant also, with the BMI very low, 14, and she's hyperelastic, typical type 3 hyper Ehlers-Danlos syndrome. with a scar of feeding gastrostomy. This is her Barium study. Classically, you see the indentation on the third part of the duodenum with dilated stomach, and the compression syndrome. You see now compression of the duodenum by the superior mesenteric artery. This is her CT scan. All the angle is very narrow between the SMA and the aorta, and this is the typical diagnosis by CT scan. And actually, the ultrasound showed also this now classically. If you are a good radiologist, can detect it. And our colleague, very clever in doing this. She has surgery duodenojejunal anastomosis, and she did very well after the anastomosis, and she is married now. Yeah, she is married now. Thank you to the radiology. Other missed vascular compression syndromes, actually, we have seen a lot of patients with hyperelasticity, which is always missed, presenting as SMA, reflux disease, mitral valve prolapse, and ecchymotic spots and easy bleeding. This is the way to examine the patients. Take it 1 minute from you to make the diagnosis. This is a sample of our patients. Now, we have seen this from mesenteric artery in 14 cases. Some of them included the renal vein, the ovarian vein, testicular vein. And this is the compression Mediterranean syndrome to the left iliac vein, renal vein. This is all documented in our area, actually. So we have this collection of about 40 cases now. We have seen one of the lateral arcuate ligament, as you see here, compression. And we have seen actually, now this is always really missed. With my suggestion to everybody that we need to have research suggestions, hyperelasticity and esophageal reflux disease, hyperelasticity and constipation, solitary rectal ulcer syndrome, SMA augmentation. We have now discussed with Mayo Clinic to treat these areas by augmentation of the area by either fat or materials. And this we just started maybe studies on animals, and then treatment with endoscopic approach. We have a few minutes to go now, yes? We have other cases now. We have seen many cases of mesenteric panniculitis. The mesentery is now a new organ in the body. This is a lady from Iraq, 63 years of age. She has recurrent abdominal pain for 10 years, fluctuating blood pressure, severe food allergy, and low vitamin D with a history of fibromyalgia and migraines. Easy bruising, fever, ataxia, rash, breast pains, clinically tympanic abdomen, fluctuating BP. Ultrasound, interestingly, showed very thick mesentery. You can see by ultrasound. And there's this CT scan, classical. It looks like a mass in the mesentery. If anybody sees it, it looks like cancer. This is typical panniculitis. And actually, her amyloid A protein was raised, raising the idea of amyloidosis as Simon mentioned now. These cases can be following the Mediterranean fever or the recurrent IgD syndrome or the periodic disease. She was treating with colchicine, doing very well on colchicine now. This is another sample. We have 12 cases of this syndrome. You see classically now here, the mesentery really involvement with these two cancers actually. This is amazing. How many cases have you seen in your area, Dr. Siraj? Did you collect these cases? In one family, we have two, and the husband and the wife have the same, and they are both Palestinians, and they take a lot of olive oil. So we put a suggestion that olive oil may be actually related. We have now 4 or 5 cases with the people from Libya, Egypt, Iraq, Algeria, and Lebanon, and Palestine, taking regularly every day olive oil. Then we are thinking that there's a relation between the two.
Dr. Maki.
Yes.
We have to stop for a while.
Okay. I think this is the last slide, and I'll go stop here. Okay.
Leads started to be confused.
Yes.
Excuse me. You presented the case of amyloidosis. Then
yes.
we celiac disease. Wait, please. Then we move.
You want the celiac?
Excuse me.
Yes.
Colorectal cancer prevention. Then we ended by superior mesenteric artery compression.
And then we'll end up with this IgG4 disease. So that's last presentation.
We have question from a young colleague.
Yes.
About the case of amyloidosis.
Yes. The causes of amyloidosis. Any chronic infection, rheumatoid, connective tissue disease, rheumatoid arthritis, Mediterranean fever. These are the main causes in our area.
بعد إذنك أنا كان بس ليا سؤال في الكيس نمبر 1 اللي هو primary amyloidosis. اولا انا بشكر حضرتك. انا اسمي منار قنديل، وانا بعتبر نفسي بنت ابو ظبي لاني يعني عشت سنوات عمري كلها هناك ولحد سن الدراسه يعني. بس انا عارفه ان في جيناتيك فاريشن كبيره بين الناشوناليتيز الكتيره اللي في ابو ظبي. بس اللي انتبهت ليه في الكيس الاولانيه إيه اللي خلانا او حصل موتيفيشن عشان اعمل بون مارو اسبريشن؟ ايه اللي كان عند البيشنت ده خلاني ليدنج ان انا اعمل بون مارو اسبريشن؟ انا لو جالي كيس زي ديت هقول البيشنت ده اميونو كومبرومايزد دايابيتيك هايبرتنسيف ماشي على ممكن يكون اي حاجه فيها اميونو سبريسنت. فلما حصل سوبر امبوزد للفانجل انفكشن، طب ما هو ممكن يعملوا ماجروجلوسيا زي ما ظهر ويحصل، وحتى كمان البيوبسي من الطنج طلعت فيها فانجل انفكشن. ايه اللي كان عند البيشنت ده خلاني يعني اعمل بون مارو اسبريت؟ هل في السي بي سي كان في حاجه؟
He had bone pain, and this was the bone biopsy was done in UK, and they showed the presence of myeloma.
Myeloma.
But we had a suspicion of myeloma initially. He had high LDH and beta 2 microglobulin, which we thought that he may have underlying lymphoma or malignancies. But he could not wait for the for the bone marrow. He went to UK and they did bone marrow aspirate, and they found that the diagnosis was amyloidosis associated with plasmacytoma.
Thank you.
Can you continue or stop here, Siraj?
Yeah, come back.
We continue?
Huh?
Okay, so this is a patient now, a child of 12, silent patient, presented with jaundice.
That's the cases. Yeah, it's too much knowledge in
Siraj, we have now this is all published. We have 12 papers published about these, Siraj. I will send to send to colleagues, because this is our area. We should know each other very well. We can have combined research on all the cases I just mentioned. This child, listen to this, Siraj, child of 12, came with jaundice, elevated liver enzymes. The ultrasound showed a large pancreas and a suspected cancer of the pancreas.
Okay.
When we see large pancreas, sausage pancreas, and this we always think of autoimmune disease, IgG4. So IgG4 came very high, and Salim, what did you, Salim? He gave steroid.
We did this X-ray, and it shows.
في مصر يا ماكي نقول ابلع ريقك.
It shows that there is intrahepatic dilatation with
in our area is overlooked.
Underdiagnosed.
Diagnosis. I am with you completely, and we discussed this 2 weeks ago, if you remember.
Yeah.
If we look for it, we find it.
Siraj, if you see this X-ray now, everybody said it's cancer. This is IgG4 related disease. She completely responded to steroid in 4 months' time. She's completely normal without surgery.
Very good. What about colorectal cancer prediction in Emirates? I think you have a program for this.
Yes. Program in the Emirates started at the age of 40 by checking fit test every year or colonoscopy every 10 years. If you have a family history, depend on the family history. If you have multiple family history member, depend on the history, whether Shafab or Lynch syndrome.
قلت بتتكلم زي بتوع الهند يا ماكي.
What really the result is amazing, Dr. Raj.
يعني بقول لك
12% below age of 40. So all the Egyptians in Egypt, there's one study showed 35% below 40. I have one study from Egypt also.
My dear, I am asking, what are the points you follow in colorectal cancer detection in UAR?
Well, we do screen it by fit test or colonoscopy.
Fecal
at the age of 40, if you have any polyp, resect polyp, depend on the polyp size and the histology, we follow the rules. I will send you the program by WhatsApp, all the detailed program from the UAE. Please distribute it to colleagues, okay?
Okay.
There are continuing a few more cases. So IgG4, we have about 40 cases now collected.
بعد إذنك يا دكتور، بعد إذنك أنا كنت عايزة أسأل بالنسبة في الإمارات بشكل عام، هل الفولو أب بتاع الكولوريكتال كانسر منحصر أو كان في يعني ناشوناليتيز معينة شفتوها بحيث إن هم كانوا أكتر الجنسيات أو أكتر أو في جيناتيك ريليشن بين الكولوريكتال كانسر والناشوناليتيز اللي في الإمارات ولا؟
Very nice question. We did one study in the church for the Indians. Very interesting. We are invited. We did a study about 1,000 of them. We were greatly surprised that when we took the Indian data and compared to the Indian living in the UAE, there was a high rising cancer of the Indians in the UAE because of the lifestyle and the diet and the pollution. We have pollution from the area, from the wars, pollution from depleted uranium, pollution from the, and at the same time, we have the diet which is heavy in sugars and fats. At the same time, the risk of obesity. We are obese, and we have the highest risk of diabetes in the area, and the diabetes and the obesity. The two of these, obesity and diabetes, put you at risk of more than 12 cancers increase. And there's inactivity. We have cars, don't walk. Yes?
Salim, I suggest a special meeting, joint meeting between us and you, Egyptian and Emirati doctors, about, and we arranged it before, about the common health problems here and there.
Hello.
But it's very nice. You know, the geographical medicine counts here. What you have is different from what we have. Your people, multi nationalities.
We have about 230 nationalities.
So,
230 جنسية.
that's it. And the problem, Salim, we have Professor Gaish from the state now waiting for liver transplantation talk. So,
okay.
Can you resume your message to the colleagues before we move?
Our message to the colleagues: please examine the patient properly. Please take good history. Please read and review everything you see. And to us, every single patient is a research topic. Remember that our area is different from other areas in the world. We see cancer 15 years younger than the West. We are seeing more celiacs. Check your celiac in Egypt. We are seeing more IgG4 diseases. We have seen more infections actually. And I think we should be aware of this. Thank you very much all. And we hope we'll do combined meeting regularly. Join our Zoom meeting every Thursday at 4:30 to 5:30. Okay? Any other comment?
Very much. Really, Baki and Salim, you always present very fantastic and interesting points.
We are proud of you.
But you need half day, not half an hour.
We are proud of you all, Habibi.
But keep online, please, to enjoy the liver transplantation with our.
Okay, thank you. Okay, shukran. Thank you.
Thank you for inviting us.